Hello everyone, this is Dr. Terkawi. I'm an assistant professor at the Department of Anesthesiology, Perioperative, and Pain Medicine in Stanford. I'm going to present to you a series of lectures in acute postoperative pain management. This is the introduction lecture. There will be 5 lectures, and I would recommend you watch these lectures in the order I put here. So the first lecture, we're going to learn about pain in general, mechanism of pain, why it's important to treat pain. We're going to go over preventive analgesia, monitoring, and assessment. The second lecture will cover opioids. Third lecture will be non-opioid analgesics. Fourth lecture will be special population. And in the fifth lecture, we'll put things together and we'll learn how to build a multimodal analgesia. So let's get started. The International Association for Study of Pain described pain in the most recent definition as unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Acute pain is normal, predicted physiologic response to noxious chemical, thermal, or mechanical stimulus. Patients with postoperative pain account for approximately 60% of emergency department visits. So, 60%. The goal of perioperative pain management are to relieve suffering, achieve early mobilization after surgery, reduce length of hospital stay, and achieve patient satisfaction. Successful pain control regimen must consider medical, psychological, and physical conditions for the patient, including age, level of anxiety, surgical procedure, personal preference, and response to agent given. Potential barriers to effective treatment of pain: inadequate patient education regarding pain and its management, providers and administrator ignorance of proper pain management protocol and responsibilities. What are the type of pain? Nonsusceptible or somatic. This is usually sharp, stabbing, aching, usually localized. An example here would be wound pain, bone fracture, musculoskeletal. Neuropathic, usually this is burning, shooting, electrical pain, usually it radiates, can be chronic, and usually related to some sort of nerve injury like postherpetic neuralgia or diabetic neuropathy. Visceral, it's more like a cramping, gnawing, crescendo pain, usually poorly localized and associated with bowel obstruction, angina, and hemorrhage. And we have psychological, which is inconsistent with an organic cause. Now, important terminology to consider. These are signs of nerve injury. So, allodynia, pain caused by stimulus, normally not painful. HyperAlgesia, increased response to normally painful stimulus. Hypoalgesia, decreased sensitivity to normally painful stimulus. Hyperpathia, painful syndrome where there is no response to repetitive stimulus until a threshold level is reached, then explosive pain response. Anesthesia dolorosa, pain occur in an insensate region. Example for this will be when we do trigeminal ganglion radiofrequency ablation, then sometimes the patient may develop this sort of complication. Sensory terms: hypoesthesia, decreased sensation to stimulus; hyperesthesia, increased sensitivity to stimulus; dysesthesia, unpleasant abnormal sensation; and paresthesia, abnormal but not unpleasant sensation. Let's talk about mechanism of pain. First of all, let's learn about the type of nerve fibers. Nerve fibers can be divided into A, B, and C. The A fibers can be subdivided more to alpha, beta, delta, and even sigma. I did not include sigma here. So alpha carry proprioception. It is myelinated, right? Actually, all myelinated except C. It is thick. This is why it's fast. Beta, it carries the touch. Again, it's myelinated. It's thin or thinner. The speed is lower. Now, delta, it carries the pain, temperature, and pressure. It is myelinated. It is thin. This is why the conduction speed is slower than alpha, for example, but it's still fast. Then we have B fiber, which is autonomic nervous system, specifically here preganglionic, again myelinated, small. C nerve fibers, again carry the pain. It is not myelinated. It is small, so it is slow. Now, that's a cut section in a nerve. You have multiple fibers. Here you have the A alpha and A beta. Then you have the delta. You can appreciate the difference in the size. Then you have the C fiber here. So the pain, usually we have the first pain, the second pain. The first pain here, usually it is brief, well localized, sharp, and carried by the A delta. The second pain, usually longer, right? Dull, burning, less well localized, and carried by the C fibers. The mechanism of pain perception is complicated. The generation of pain originates from local inflammation and nerve damage, typically associated with invasive procedure, trauma, surgery, etc. These processes result in a release of local mediators, for example here, the bradykinin, histamine, serotonin, prostaglandin. We'll go over this. Nociceptors are sensory receptors that respond to these local mediators and send afferent, which is sensory signals, toward the spinal cord and then to the cerebral cortex. Now, the nonsusceptible pathway is an afferent, the picture in the right side, which has 3 neurons, dual ascending, the anterior lateral, dorsal column, medial lemniscal, and then we have the descending modulation, this guy here, from the cortex down, thalamus, all the way down to the peripheral. So nociceptors are free nerve ending located in skin, muscle, bone, and connective tissue with cell body located in the dorsal root ganglion. First order neuron originate in the periphery as A delta and polymodal C fiber right there. The A delta fiber transmit the first pain, as I mentioned, which is described as sharp or stinging in nature and is well localized. Then the polymodal C fiber transmits the second pain, which is more diffuse in nature and is associated with affective and motivational aspect of pain. Then we have the second order neuron, which is at the dorsal horn, primarily within the laminas 1, 2, and 5, where they release excitatory amino acid and neuropeptide. The second order neuron consists of nociceptive specific and wide dynamic range neuron. Nociceptive specific neurons are located primarily in lamina 1, respond only to noxious stimuli, and are thought to be involved in the sensory discriminative aspect of pain, while wide dynamic range neurons are predominantly located in lamina 4, 5, and 6, respond to both non-noxious and noxious input, and are involved with the affective motivational component of pain. Absence of both nociceptive specific and wide dynamic range neuron ascend the spinal cord via the dorsal column, medial lemniscus, and the anterior lateral spinothalamic tract to synapse on the thalamus, in the contralateral thalamus, which is the third order neuron. So the third order neuron in the contralateral thalamus, which then projects to the somatosensory cortex, where nociceptive input is perceived as pain. Now, what are the 4 elements of pain processing? Transduction, transmission, modulation, and perception. Let's learn about it. Transduction is the event whereby noxious thermal, chemical, or mechanical stimuli are converted into action potential. Transmission occurs when the action potential is conducted through the nervous system via the first, second, and third order neuron, which have cell bodies located in the dorsal root ganglion, dorsal horn, and thalamus, respectively, as we learned from the previous slides. Modulation of pain transmission involves altering afferent neuronal transmission along the pain pathway. The dorsal horn of the spinal cord is the most common site for modulation of the pain pathway. The modulation can involve either inhibition or augmentation of the pain signal. Let's see. Examples of inhibitory spinal modulation include the release of inhibitory neurotransmitters such as GABA, glycine by intrinsic spinal neurons, and activation of the descending efferent neuronal pathway, which results in the release of norepinephrine, serotonin, and endorphin in the dorsal horn. We would like to have inhibitory modulation, right? Spinal modulation, which results in augmentation of pain pathway, is manifested as central sensitization, which is a consequence of neuronal plasticity. Phenomena of wind up is a specific example of central spasticity that results from repetitive C fiber stimulation of the WDR neuron in the dorsal horn. Of course, we don't like to have this happen, and we're going to learn during these lectures how we can prevent this from happening, hopefully. The fourth element is the perception, right? Perception of pain is the final common pathway, which results from integration of painful input into the somatosensory and limbic cortex. Generally speaking, traditional analgesic therapies have only targeted pain perception. Chemical mediators of transduction and transmission. Tissue damage following surgical procedure lead to activation of small nociceptive nerve ending and local inflammatory cells like the macrophage, mast cell, lymphocyte, platelet, which end up releasing a bunch of substance here, as you see on the table. So, for example, bradykinin get released from the macrophage and plasma kinogene, and it activates nociceptors. You have serotonin from the platelet, histamine from the platelet, cause vasodilation, edema pruritus, prostaglandin, you have leukotrienes, excess hydrogen ion, and a bunch of cytokines, mainly here the interleukin, released from the macrophage, which again excite and sensitize nociceptors. Adenosine and more neurotransmitters like glutamate and substance P, and nerve growth factor, which again release from the macrophage and stimulate mast cell to release histamine and serotonin. Induce heat hyperalgesia sensitizer nociceptors. An important concept here is when you have a tissue injury, tend to fuel neuroplastic changes within the nervous system. This is called neuronal plasticity, which results in both peripheral and central sensitization. Clinically manifest as hyperalgesia, which is defined as an exaggerated pain response to a normally painful stimulus. So, for example, let's say you have a pain stimulus at this level. In normal people, this should give you about pain score of 2, correct? However, when you have hyperalgesia, that would be equivalent to 10. This is hyperalgesia. Allodynia defined as painful response to typically non-painful stimulus. So, for example, if you have a stimulus right there, usually should not be painful. But in this patient, it is painful. This is called allodynia. So understand the difference between hyperalgesia and allodynia. Now, at the molecular mechanism of sensitization, we have two types of sensitization: peripheral and central. Let's learn the difference between them. Peripheral, from its name, it occurs after tissue damage and inflammation, post-translational and transcriptional changes in the terminal end of high-threshold nociceptors. Due to direct activation of peripheral receptors, polymodal C fiber and high-threshold mechanoreceptor release chemical mediators, like the substance we saw in the previous table. Chemical mediators like bradykinin, prostaglandin, substance B, heat, and frequent stimuli, where events around the damaged site combine to allow a lower intensity stimulus to evoke action potential in the fiber. This will lead to primary hyperalgesia, which is an exaggerated response to pain at the site of injury, as we saw. Again, example, hyperalgesia at the site of injury. While on the other hand, the central sensitization is an increased responsiveness of nociceptive neuron in the central nervous system to their normal or sub-threshold afferent input. Where even at the changes here, even at the spinal cord and CNS, this is why called central sensitization happen, occur due to wind-up, remember the wind-up phenomena, and sensitization of the second order neuron and wide dynamic range. Through neurochemical mediators, again, slightly different mediators here, like calcitonin, gene-related peptides, substance B, and MDA, and repetitive repetitive C fiber stimulation of the wide dynamic range neuron in the dorsal horn at an interval of 0.5 to 1 Hz can precipitate the occurrence of wind-up and central sensitization. Now, longer-lasting effects are due to alteration in the microglia here, stereocyte, gap junction, membrane excitability, and gene transcription, all of which can contribute to maintenance of central sensitization. This leads to tactile allodynia and secondary hyperalgesia, which define as an increased pain response evoked by stimuli outside area of injury. Can you think about an example? Yes, complex regional pain syndrome. Okay, let's shift gear now and talk about why it is important to treat pain. The inadequate relief of postoperative pain has adverse physiological effects that can contribute to significant morbidity and mortality, delay of patient recovery and return to daily activities, increased cost of care, patient dissatisfaction with the surgical experience and may have adverse psychological consequences, increase the incidence of persistent post-operative pain condition. In special situations like post-C-section, also it can cause breastfeeding issues and postpartum depression. Because aggressive treatment of acute postoperative pain is so beneficial, the Joint Commission of Accreditation of Healthcare Organization, JCO, has declared that pain is the fifth vital sign, and all institutions seeking accreditation from this group must develop pain management program. Consequences of poor managed acute pain. As you see, it affects every single system in the body. Cardiovascular can cause tachycardia, hypertension, increased cardiac workload, and you know that what can cause in terms of ischemia, myocardial infarction, etc. Pulmonary, respiratory muscle spasm, decreased vital capacity, telectasis, hypoxia, increase the risk of pulmonary infection, pneumonia, gastrointestinal, ileus, renal, increase the risk of oliguria and urinary retention, coagulation, increase the risk of thromboemboli, DVT, immunologic, impaired immune function, and even some references think they increase the risk of infection, muscular, muscle weakness and fatigue, limited mobility, psychological anxiety, fear, frustration, and in children, undermanaged postoperative pain might lead to prolonged up to 1 year risk of changes in behavior. Okay, here is a study, a little bit over than 1,000 patients included in the final analysis, patient who had multiple types of surgeries. The researchers found that the incidence of moderate pain, defined by a pain score from 4 to 7, occur about 40%, 37%, 32% of patients in postoperative 1, 2, and 3, respectively. Severe pain occurring 16, 10, and 6% in postoperative day 1, 2, and 3, respectively. Overall, almost 70% of patients reported unacceptable pain at least once during the first 3 days postoperative. Now, postoperative complication was defined by the author as any medical adverse outcome occurred between admission and 30 days after operation. Having postoperative pain was assessed in 2 ways. The movement evoked pain score and patient opinion whether they have acceptable or not acceptable pain. Outcome was the presence of complication within 30 days after day. And as you see in the graph here, the more you have severe pain, the more you increase the proportion of patients that have complications. Then they looked at here pain with movement, and here if the patient reported unacceptable pain. They looked at a variety of surgeries, as you see. Overall, when they pooled the result of whether having pain with movement, moderate and severe pain with movement, whether that will associate with complication, that didn't reach statistical significance here, as you see. However, it was statistically significant and clinically significant for those reported unacceptable pain. So you get the point. If you have a severe pain, that's really correlate very well with the incidence of mortality and morbidity 30 days after surgery. Now, let's learn how we're going to assess pain. Because pain is subjective component of perception, the assessment of pain and the treatment of pain rely heavily on the use of self-reported pain scale. Example, you have the self-reported pain scale here, the verbal rating scale. Basically, you ask the patient, do you have pain? If yes, can you rate that pain for me from 0, which you don't have pain at all, to 10, the worst pain ever. And also you have the visual analog scale, where you can show the patient these faces and let them point to you, to the face or to the number. Proper diagnosis of the type and intensity of pain is crucial for an adequate and targeted treatment of acute pain. The patient should feel sufficient empathy on the part of healthcare professionals. The examination of acute pain should include medical history, physical examination, and specific evaluation of pain. Factors affecting postoperative pain. The intensity, quality, and duration of postoperative pain is affected mainly by location, type, duration of surgical procedure, type and extent of incision, physical and mental status, preoperative psychological and pharmacological preparation, type of anesthesia, pain management before and after surgical procedure, incidence of surgical complication, quality of postoperative care. Providers usually focus on pain at rest. However, we have to ask more than that. Rarely ask patients about whether they have pain with movement, breathing, bowel movement. This is why you have to be thoughtful when you ask the patient. So when you go and ask about pain, you need to know the onset. You need to temporality, site of pain, radiation, quality, nature of pain, whether again nonsusceptive, neuropathic, muscle spasm, etc. Intensity of pain, severity, again with rest, movement, breathing, coughing, bowel movement, exacerbating factor, relieving factors, response to analgesic, respond to other intervention, associated physical symptoms, associated psychological symptoms, and interfere with daily activity. After that, you have to do a physical examination, a thorough physical examination, which also need to include neurologic examination, such as finding that indicate nerve injury, like altered sensation, HyperAlgesia, allodynia, we mentioned that. Okay, let's learn about risk factors and predictors of severe postoperative pain and chronic opioid use. Predictors of postoperative or severe postoperative pain: preoperative pain, anxiety, young, obesity, surgical fear, catastrophizing, type of surgery like abdominal, orthopedic, thoracic, long duration, type of surgery, again, age, psychological distress, predict postoperative analgesic consumption as well. Okay, we'll touch base briefly on this concept of chronic postoperative pain. So chronic post-surgical pain defined as the follow: pain that persists at least 3 months after surgery, pain not present before surgery or that has different character of increased intensity from preoperative pain, pain located at the surgical site. Other possible causes of pain are excluded, like cancer recurrence and infection. The incidence, roughly about 10% from all surgeries. However, there are certain types of surgery with higher incidence, for example, 35% after thoracotomy and breast surgery, 20% or 15% after total knee arthroplasty, and 10% after hip arthroplasty. The intensity determined by different factors. Potential risk determinants of persistent post-surgical pain, multiple, as we will see here. So you have preoperative factors, intraoperative factors, and postoperative factors. Preoperative, patient-related environmental comorbidities, as you see here, anxiety, catastrophizing, depression, gene, etc. Intraoperative, again, if you have a nerve injury, tissue ischemia, surgical technique, anesthesia technique, post-inflammation, etc. Postoperative pain, the most important, always shows in the literature, in the research, predictor of chronic post-surgical pain is poor management of the acute post-surgical pain. If you have severe acute post-surgical pain, then that's the most important predictor of chronic post-surgical pain. Okay, here is a study, very large sample, as you see. They looked at patient who had minor surgery and major surgery, and the inclusion was they don't have opioid prescription in the first 11 months before procedure. Then perioperatively, if they have more than one opioid prescription, 30 days before procedure, day through 2 weeks after discharge. And they looked at these people up to 180 days after surgery, and they looked if there is any prescribed opioid for them. So they found that the rate of new persistent opioid use were similar between two groups, the minor and minor surgery, interestingly. But look at that compared to the control group who haven't had surgery, which means that surgery here is, of course, a risk factor for using opioid, like persistent use of opioid. Now, risk factor independently associated with the new persistent opioid use include tobacco use, alcohol and substance abuse disorder, mood disorder, anxiety, preoperative pain disorder, and centralized pain. Here is another study, very large sample size from Stanford. The study included more than 500,000, actually, with surgery, and almost 2 million with no surgery. And among the surgical patients, the incidence of chronic opioid in the first preoperative year ranged from 0.119 to 1.4. The baseline incidence of chronic opioid use among the non-surgical patient is way lower. Again, the same concept, except for cataract surgery, laparoscopic, and FIS and TURB, all surgical procedures were associated with an increased risk of chronic opioid use. Again, factors associated with new opioid use, male, age older than 50, preoperative history of drug abuse always shows, alcohol abuse, depression, benzo, antidepressant medication. Okay, now let's talk about a very important concept called preventive analgesia. Preventive analgesia include any anti-nonsusceptive regimen delivered at any time during the perioperative period that will attenuate pain-induced sensitization. The term preventive analgesia replaced the old term preemptive analgesia, which is defined as analgesic regimen that is administered prior to surgical incision and is more effective at pain relief than same regimen administered after surgery. Remember those in the days where you give a high dose upfront of opioid before even the surgical incision? Although use of term preemptive analgesia has been popular in the past, evidence of its clinical benefit in a human has been mixed, and the term should be considered not right. The goal of preventive analgesia to block, that's the key word, the development of sustained pain. Theoretically, this occurs by preventing NMDA receptor activation in the dorsal horn that is associated with wind-up facilitation and central sensitization, expansion of receptor field, and long-term potentiation, all of which can lead to chronic pain state. Now, in order to prevent analgesia, to develop, to give a preventive analgesia to be successful, there are three critical principles must be adhered to. First, the depth of analgesia must be adequate to block all nonsusceptive input during surgery. Second, the analgesic technique must be extensive enough to include the entire surgical field. Third, the duration of analgesia must include both the surgical and post-surgical period. Very important concept. Patients with pre-existing chronic pain may not respond as well to those technique because of pre-existing sensitization of the nervous system. So from now on, I want you to remember these three principles. We're going to build our multimodal analgesia eventually based on these three principles. Remember, the depth of analgesia, the extent of analgesia, and the duration. Okay, now let's look at some indicators, objective, I should say, indicators of good postoperative analgesia. How are you going to know if you are providing a good postoperative analgesia? Okay, interestingly, this is a very recent article published in Anesthesiology. They found mobilization time. Mobilization time was almost 2 hours per day for patients with average pain score of 3 or lower, but only 1.2 for those with average 6 or greater. What does that mean? Well, they found that for each unit increase in average pain score was associated with decreased mobilization time of 0.12 hour per day. Interestingly, no association between postoperative opioid consumption and mobilization time. Again, the incidence of composed postoperative complication was, so they looked at the quartile. So the first quartile, they found the incidence, which is the people with poor mobilization. The incidence is 6%. In the second quartile, the incidence is about 4.2, and then interestingly, the The upper quartile, which is the third quartile, and the fourth quartile, the incidence was 0. So mobilization duration correlates with complication and correlate with pain intensity. So if you really want to know if you are doing a good job with the pain management, look at the duration of mobilization. Other one, incentive spirometry. This usually reflects the patient ability to take a deep breath, cough, and again, this is a recent study here. In 100 patients, they found a strong correlation between the incentive spirometry and complication and pain management. Then sleep duration and quality. This is a bidirectional relation. That means if you have a poor sleep, you will have more pain, and if you have more pain, you will have poor sleep. Ability to eat and ability to have a bowel movement. There is no much evidence here. That's why I put them in the black color. However, they are important indicators. Postoperative monitoring. So now you are giving pain management. It is important to monitor patients who receive pain management, continue management their pain as they respond, and detect any side effect. So you're going to look for side effect here, and routine monitors here will include vital signs, temperature, heart rate, blood pressure, respiratory rate, average pain score at rest, activity, etc., and use of breakthrough medication. Look for side effect, cardiovascular, which will be hypertension, bradycardia, tachycardia, etc., respiratory, nausea, vomiting, pruritus, urinary retention, neurological exam, assessment of motor block or function sensory after epidural, for example, and always talk to the patient, give some instructions, educate them about side effects, look for any CNS depression, and set up a parameter that trigger pain notification for the providers. Okay, now let's put things together before we wrap up this lecture. So here is an infographic for you that will summarize for you as an APS service, acute pain service or anti-pain service, whatever you like to call it. When you go and see the patient the first time and every day, what you need to assess and how you're going to plan. So pain assessment. Pain score at rest and movement, as I mentioned, over the past 24 hours. Over the past 24 hours. It's important to have a pain chart because you want to know if you're really applying a preventive analgesia, right? It's not important to ask the patient about pain now. Then when you have a pain, you have to look for description of pain, location, character, nature, severity, exacerbating, relieving factors, radiation, etc. Now, look and ask if the patient had a past chronic pain condition, past pain medication, type, amount, what medication did work best for the patient in the past, any side effect from this medication. Look for predictors of severe pain and persistent pain and opioid consumption, as we mentioned, anxiety, catastrophizing, previous addiction, alcohol, smoking, substance abuse, etc. And it's even better if you can use quality of recovery questionnaire. Vital sign and consumed pain medication. Look for blood pressure, heart rate, respiratory rate, saturation, again over 24 hours. Assess the mental status. Look for the amount of opioid consumed and other analgesics over the past 24 hours. Surgical condition. Is the patient NPO or we can give oral medication? Is there any position restriction that prevents certain amount of procedural pain, for example? Presence of surgical complications. Is the patient having infection? Are they going back to the OR for debridement or something like that? Concomitant medication and diseases. Check for drug interaction and contraindications. Is the patient taking any B450 inducers and inhibitors? Is the patient started on anticoagulant or antiplatelet? Look for the liver function, kidney function, cardiovascular disease, bleeding disorder, and its implication for drug selection and dosing. Look for indicators of good pain management. As I said, duration of ambulation, incentive spirometry, sleep duration, quality, ability to eat, ability to have bowel movement. Side effect and complication. Side effect related to your medication: sedation, drowsiness, nausea, vomiting, urinary retention, delirium. Specific for specific medication like ketamine, look for hallucination, agitation. Lidocaine, look for ringing in the ears, perioral numbness. If you have epidural, is the epidural functioning? Test sensory, test motor. Look for any side effect, any opioid-induced itching. Rule out any complication. Check the catheter side. Check the pump. Nerve block, the same thing. Check the catheter. Check the side. Examine the for motor and sensory. And think about discharge and rehab plan. Is there a plan for discharge date and time? Where the patient gonna go? Is there someone gonna take care of the patient at home? Ask about patient satisfaction and feedback. And if the patient is at risk of chronic post-surgical pain, then please consider early referral for pain physician. These are more references. I hope you enjoyed it. Thank you for your attention. Please don't forget to subscribe.